Good morning to everyone in the room. It's been nice chatting with some of you. Good morning to or afternoon, wherever you are online. Thanks for joining us. As Sally said, I'm Susan Lamb. I'm a historian of medicine, and for the last 10 years, I've been fortunate to be teaching in the Faculty of Medicine at the University of Ottawa. Like some of you, I imagine I don't live in the city of my university. I actually live in Montreal, which is 2 hours away by car, which I mention simply because if you find yourselves in Ottawa or Montreal, please do reach out. Let's get together if you can. I would love that. I'm really grateful to Erica Charters and Sally and Richard and everyone who helped organize this. Thanks for the invitation. I hold, as Sally said, I hold something called the Hannah Chair in the History of Medicine at University of Ottawa, and this is one of 9 such chairs in Canada for history of medicine. 2 of them newly endowed in the last 5 years, thanks to vigorous fundraising on the part of the home institutions as well. And so before I discuss this teaching method that I call History's Toolbox, I thought it might be worth saying a little bit more about AMS Healthcare, who funds those chairs, since we are all humanities scholars working in clinical contexts. So I'll do that. Spacebar, right? She said spacebar. Yeah, I did something.
Maybe
There we go. Okay, let's try it. Oh, hopefully Sally doesn't have to help me on every slide. So I thought it just might be helpful to have a little bit of detail. And here are most of the Hannah chairs over the years. Dr. Jason Hannah endowed the original 5 chairs in history of medicine in the 1970s in medical schools. He made that part of the deal, not with commercial profits per se, the way Henry Wellcome did, but it was that he was the founder of a nonprofit healthcare scheme, medical insurance scheme in the 1930s in Ontario, in Toronto, Ontario. So families and workers could have access to GPs and specialists by paying a small subscription to the insurance scheme every month. And with all insurance companies, whether they're for profit or not for profit, they need to collect the subscriptions, they need to invest them, they need to make a float, it's called. A big pile of money to pay out the claims when patients go see physicians and get the physicians paid. So when Canada introduced its state-funded healthcare insurance in the 1950s, the government of Canada told medical insurance companies, you can either give that big pot of money to us and we'll put it in the state fund for health insurance, or you can start a charity, and that's what Dr. Hannah decided to do. So the Hannah money and AMS Healthcare, which was the name of the medical insurance company, they're one and the same. And I like to say that the Hannah money is Canada's much more modest but mighty version of the Wellcome Trust. We're very fortunate to have that support. AMS Healthcare funds the Canadian Society for the History of Medicine and its journal. It helped to start and fund the Canadian Association for Health Humanities. It does book publishing subventions, graduate and postdoctoral fellowships and project grants, and gives the Hannah chairs, including me, research for money for research and teaching. And that's always key too, because the AMS is always very clear that the Hannah chairs are allowed to use this money not only for research, which some grants stipulate, but for teaching interventions, especially AMS Healthcare is especially interested in things that go towards medical training. So I thought this might be worth highlighting. There we go. So back to History's Toolbox, which is a teaching method I developed working with medical students. It's not research, I wouldn't say. In fact, when I published on it, which I'll show the citation at the end if you're interested. The editor wanted to change it to this article, and the first sentence, and I said, no, it needs to stay this report. It's a report on my teaching method, FYI. There's no findings here, but I hope that perhaps it could be an entry point to talking about research on health humanities. That's sort of the term that's on the tip of my tongue that we're using in Canada these days, health versus medical humanities. We can talk about that. So hopefully it'll be helpful to you, is what I'm trying to say. And I developed it to help medical students and other clinical learners approach sociocultural complexity. That was the plan. So my presentation plan is the following: to tell you briefly how it developed, present its rationale, present the tools, which are in some ways simply categories of analysis with which most of you, all of you, are certainly familiar. So I am feeling somewhat chagrined that I'm talking about things that most of you in the room will simply find, yeah. As I once heard Dr. Phil say, put that on the cover of the Duh journal. But I'll present to you how I use it with clinical learners who don't have that humanities training, and we'll see what we can learn and discuss about that. And then finally, I'll try to have you try out the tools a little bit in the context of a humanities activities with clinical learners, so in the context that I use them. So in terms of its development, the method emerged organically in the classroom. Honestly, not with medical students, but beforehand with undergraduate science students, most of whom wanted to become medical students. So during my PhD training, I was a teaching assistant for the same two courses 3 years in a row. One was a history of science course, and one was a history of medicine course with these undergraduate, mostly science students, not humanities students. And the majority of these science majors thought, well, if I have to take a humanities course, at least let it be history of science or history of medicine. That'll hopefully stand me in good stead. But they were terribly concerned about how to do well on a history exam, as I'm sure lots of you have encountered. With long answers. They knew how to do well on science exams, but they could not fathom how to take what we were talking about in the lectures and the sessions, the tutorials, all that mess of detail, and turn it into a comprehensive or a coherent exam question. So I promised them that each week, as we discussed the lecture and reading material, I would flag core themes and factors in real time as we were talking about the material, whether it was medieval physicians forming a guild, or Lady Montagu's influence on smallpox inoculation, or 19th century scientists theorizing about racial difference. I would sort of interject into our discussions each week, hey, now we're talking about politics again. Look at that. So I'll write politics on the board, right? We're talking about gender again. I'll write gender on the board. So trying to provide some structure, some ballast, some predictable landmarks or patterns, which scientists are really good at doing and really need, for material that can really appear to the untrained eye as just a mess of detail. That's cannot be disentangled. And what the students and myself observed was the list was always the same. The list on the chalkboard was always the same. Spoiler alert, they're the tools in history's toolbox. So it was helpful to me as a budding historian as well. And I encourage the students these undergraduate science students, to refer to the tools, these tools that, when they wrote their exam questions, make sure they hit 3 or 4 of them, and make sure their answers explicitly said, this is a social fact, and then there was also a gendered component. And so what happened over the years is that my sessions tended to do better on the history exams than others. And because it was the same 2 profs 3 years in a row, we all kind of eventually noticed. So that told me something as well. Now, at the same time, I thought this was going to be like 2 minutes, but I think this will be helpful. At the same time, in my own graduate studies, I was reading a special issue of the Journal of Social History on the futures of social history. This was 2003, which meant a lot of the articles were also discussing the past, social history's past. And 3 articles in particular had a real impact on my understanding of how historians worked. Fass and Eustace and Gasson here, I've got the citations on the image. They all drew useful distinctions in their own ways. They all drew useful distinctions between social and cultural history and their respective frames and approaches. And Richard Gasson's piece especially really resonated with me at the time while I was in graduate school, because he was writing about his experiences going into a history PhD program from another career, which I had also done. And explaining his bewilderment, which I at the time was experiencing, at realizing that what you're really learning to become an expert in is the historical profession itself, at least initially, not the past, but how historians approach the past and how they justify and disagree about what those approaches are. And that your expertise about your own subject matter evolves from this historiographical expertise that comes in the first couple of years of training. So it really helped also that I was training at an institute for the history of medicine. So we had about 8 to 10 different kinds of historians of medicine around all the time. And they were having robust but respectful conversations and discussions about approaches in social versus cultural history. And this also included Mary Fussell, who some of you may know, who championed the idea that cultural history attends especially to meaning making versus some of the social history techniques. So all of that provides some context for History's Toolbox that I'm going to tell you about from the learner and the teacher side. Okay, so the rationale, this is really a pitch, which you may or may not buy in all or any of its aspects, and that's okay. Little interactive part, if you will indulge me, the people in the room. I don't think everyone online is on camera, but please join us at home if you feel like it. We're going to do a sort of show your hands interaction here. And it's to highlight the role of terminology and specialized terminology. So terminology is helpful, often cases fundamental to the study and analyses of any phenomena. And terms often help categorize phenomena. Again, I feel like I'm saying such simple things to a room full of people who already know this. But both terms and categories are tools for evaluating and analyzing, not just clinical work and research, but everyday life. So here's the interactive part, if you would indulge me. If you could like raise your hand or do jazz hands or whatever. If you're certain about the difference between the following pairs of terms. So show of hands, some sort of show of hands. So they're all adjectives, okay? That is their descriptors. That's important to the clinical learners to sort of make plain. So here we go. Here's the first one. Who is absolutely clear on the difference between single and double? Single and double. Good, that's excellent. Provincial versus federal. Oh, that's a Canadian one. Sorry. Yes, Martin, Robert, Erica Charters, yes, Lunan, hi. Yes, excellent. Okay, so there's different versions of that. Okay, but that was good, actually. Deciduous versus coniferous. So I know that. Okay, good, excellent, excellent. Theoretical versus applied. I'm good on that. Yeah. Technical versus technological. Technical versus technological. You see, that one requires, yes, exactly, exactly. Now we're getting more specialized here. What about thoracic versus cranial? Yeah, clinicians, people who work with clinicians in the room. That's easy, right? If you're medical. A Jurassic versus Cambrian. I don't know. I'm not putting my hand up. Very good, very good. Last one, the penultimate one, syntactic versus semantic. Oh, the philosopher, yes. My husband's a computer scientist. He's a computer language expert. That's important. Okay, what about social versus cultural? I'm going to say I am because I've decided I am. But okay, wow. Okay, so this exercise I do with clinical learners and clinical audiences just to get in the space of why we use categories and what they do for us, right? They're often shorthands, which we can discuss the problems with that later. So this teaching method, History's Toolbox, is based on a correspondence between analytical categories commonly used by humanities scholars and many social scientists, and epidemiology, social determinants of health. And also, it relates to objectives that medical schools, at least in the UK and Canada still, um, objectives we have around equity, diversity, and inclusion, right? All of which are essential, I say, and others say, to health professions education. So what I continually saw and see as a historian teaching in a clinical setting is that health professions education lacks tried and true tools for dealing with sociocultural complexity. Just as diagnostic signs carry immediate and specific implications for clinicians, each of these descriptive terms indicate to a historian quite specific types of factors and forces. And I guess my argument is that these basic tools that historians and other humanities and social scientists use can be helpful to clinical learners, and they don't take up very much room at all in the clinician's clinician's black bag, especially when we're thinking about social determinants of health and equity, diversity, and inclusion, and equitable healthcare. I'm going to note that I keep using the term learners here rather than students, and we can certainly talk about those terms during the roundtable or during the question. I know that there is a distinction, and I'm using learner here quite consciously, because in this session, which I often teach as a one-off in 3 hours, they're in, they're out, boom, they really are learning. They're not studying, they're learning. And I want those clinical learners to come in and get out very efficiently, having learned something that they can now go use. So to me, that's one of the advantages. So social determinants of health are no longer solely the concern of epidemiology and public health. We know that healthcare providers share the responsibility of determining how social determinants of health affect their patients' health outcomes. For example, the project to rebalance and integrate medical education, which was an American project, said, quote, medicine is a profoundly social enterprise and that physicians must be able to identify and critically appraise medicine's social dimensions. So that was a recommendation for physicians. Another example, the American Academy of Family Physicians concluded recently that, quote, culturally proficient healthcare makes use of patients' own language and culture, quote, as tools to improve outcomes. So each individual's own unique context, in other words, enters into access to healthcare, diagnosis, and treatment. Most urgently, medicine and medical education must reflect the reality that race is a social construct. That's my argument. A social, not biological category. So that's another rationale for conveying these tools. High quality, equitable medical education and patient care then depends on competency around socio-cultural factors that not only determine health, but determine equitable and inclusive access to primary care, specialist care, and also the health professions. Yet, there's no clear consensus in the medical literature on what distinguishes social from non-social determinants of health. There's no concrete pedagogies that I've been able to find yet, and my search is probably more than a year old, I'll acknowledge, on how to teach or assess competency around social cultural complexity. And there's no definition of the term social or how it differs from the term cultural. As we saw in this room full of experts, when I said, who's certain about the difference between the term social and cultural, only a couple of us put up our hands. So how can we expect often young, medical students who aren't experts in this stuff to be able to just suddenly be able to implement socio-cultural, be attentive to these kinds of factors. Another way of saying it is that we're asking our clinical learners to take on big responsibilities around sociocultural complexity without equipping them with clear definitions or tools. So what are these tools? Again, I already told you, this is sort of, we're into the pitch where you're telling your dean of medicine or your curriculum, committee, like, you should let me do this, right? So like all academic researchers, historians have a duty to explain and not simply describe the phenomena they study. And historians study change and continuity over time. That's what we study. A lot of people don't realize that outside our profession. Unlike our counterparts in the sciences and some social sciences, including epi, we perform analyses on context-dependent phenomena that cannot be measured or quantified. Again, something we can discuss. And one of the ways we meet our burden of evidence is to employ categories of analysis to disentangle what are, we all acknowledge, interdependent factors. So at the center of this pedagogical approach is 8 tools, what I'm calling tools. They're categories, they're terms, they're analytical categories that learners are going to use hopefully efficiently. And those analytical categories, the tools are here listed on the slide: social, cultural, intellectual, technological, political, economic, gendered, and racial slash ethnic. And I'm going to discuss these in turn. Of course, there are many more categories that historians and social scientists use, but I keep it to 8, again, because it's a single session, often a one-off session, and it's an introductory session, so you can't overwhelm people either. So the core skill of this session is to dismantle complexity momentarily into its multiple and interconnected causal factors, which provides greater immediate insight into the whole. That's the core skill. And as I don't have to tell you, but as I explain to clinical learners and colleagues, each of these is an adjective or a descriptor, and it indicates to a historian a specific type of causal factor or causal factors and forces, or you could say determinants. Historians employ these categories to identify the drivers and consequences of complex historical phenomena, and we then evaluate the interrelationships among them. And based on our evidence and analyses, we can also rank relevant causal factors for their significance. So this is often totally new information to clinical audiences that, that historians and other humanities scholars can sort of take this mess of detail and begin to try to sort it out, and not only sort it out, but provide evidence for making a case that this factor, these set of factors over here, we should pay more attention to those than maybe these. And this is why. So this is sometimes new information to them. So now I'm going to present how I define the tools to the learners in the session, which I do the way I'm going to tell you about them. And then after that, I do a demonstration of the tools where basically I lecture on a subject, a historical episode that contains a lot of sociocultural complexity. And I do what I started doing with those undergraduate science students, is I tell people about the history, and I give the little lecture, but I stop and I say, you see how this meets the definition of what I said was a social factor, a social way of looking at things versus a culture. So I stop and start, and we talk, and I sort of demonstrate how I can use the tools when you're hearing sort of a lot of details that all seem context dependent and can't really be put into any kind of pattern recognition, right? So I'll present the tools the way I present them to the learners, and I'll make a case for why I pair them and contrast them or pair them together as dynamic pairs. And then I'll explain why I'm foregrounding the microscope as an important concept in this approach. Okay. It's the part I've been kind of nervous about. I think it's because I'm all quite aware that you are familiar with these terms. But this is how I sort of present it to learners who either haven't thought about this since their undergraduate degrees or high school. And now I'm presenting it in a way that I want them to be able to use it alongside or in conjunction with their clinical thinking that they're learning about, their clinical judgment. So I start, welcome. I start with the social category. This is the social from the social determinants of health, which medical students hear so much about constantly that they must know about these and they must be attuned to how they matter to patients and communities. So I start with the social and social determinants of health, which again is poorly defined in the medical literature. And this is what I tell them. First, that the term social is the adjective for the noun society, which is not intuitive. And often this is enough to create a shift, not just in a clinical learner, but in anybody who has never thought about that before. Because we have this word social all the time, right? Social media, I'm going to a social, and oh, he's so social. And so it's really a cue to clinical learners to say the way we're going to consider this word, this term today is in this way, where it can be the adjective for society. And I let them know that when they hear when they're thinking about social factors or calling something a social determinant of health, it's referring to society. And of course, society is by definition a group, numerous people, numerous humans getting together. And I emphasize that it relates to not only societies, but how societies are set up, right? How they're structured. Again, I'm getting a little flummoxed because I feel like I'm just telling you things you already know. I emphasize that the way societies are structured are through official, sort of on the books ways, right? Like laws and policies and rules, anything that's, but also off the books, but still enforceable, right? So social norms, racial categories. Again, I almost jumped ahead of myself. I try not to say racial categories. I just say category, ranking people according to relationships, right? Hierarchical relationships. And then I emphasize when you hear the word social, when you hear the term social, I want you to think structure, 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 versus, or in contrast to, the term cultural, which, again, taking from historians' conversations about the differences between being a social historian who may be looking at relationships and looking at groups and looking at what that tells us about the past, versus looking at meaning making among our fellow humans in the past. And so I emphasize that when they think about a cultural factor, I want them to be looking for a factor in our case study where humans are meaning making. They're making meaning from their experience of the world, and then applying that to either their behavior or the way that they proceed. And that meaning is often done through symbolization, language, gestures, jokes. This all, gifts, memes. Memes are such a great entry point to talk about meaning making with people who are on social media. So to think about the difference between structure and meaning. So I emphasize with this slide, these are the slides I use with the clinical learners, that when you're thinking about cultural factors, you're thinking about meaning, meaning, meaning. So we'll come back to that. The next pair, I'll put up both immediately. I don't think I need to say a lot about these. I don't usually need to say a lot about these with clinical learners because they're intuitive. I do point out that the adjective political refers to policies. Some people never think about that. Again, we're humanists, so our bread and butter is language, right? So a lot of my understanding and the way I approach this is through language. So pointing out that political refers to policies and those who decide them. Clinical learning, I mean, people have a good idea of what's meant by an economic factor, but it's a way of breaking down, again, the mess of detail into exactly what kind of factors are in play in this socio-cultural complexity. So I won't say too much about those. They obviously pair well together. The next pair, I would say, is not as intuitive, which came through when I asked if who in the room was really clear on the difference between technological and technical, which again could be a discussion. I mean, I didn't invent any of these definitions, but these definitions are definitely up for discussion. I mean, it's not like 2 + 2 makes 4. This is humanities, right? It's all worth thinking and discussing. So obviously technological factors refer to technology, but also techniques, I explain. And again, non-humanists don't spend a lot of time considering the difference, but I've really seen how it's helpful to explain this difference to clinical learners when you point it out. For instance, that the technology is the sewing machine, but the techniques or even the needle and thread is the technology. But the techniques that emerge from that technology being available, all the different kinds of sewing techniques, hand sewing, machine sewing, cross stitching, serging for the sewers in the room. Those are all the techniques. And this leads to the next helpful bit of info is that the next bit of information that I have also seen very sort of quickly transformative for learners thinking is that all technology emerges from ideas. Technology is what is the product of when a human says, you know what, I have this idea that I think I could do, or we could do. What if, how we found those nuts open and there was the shells and there was nuts inside? Like, what if we could actually open the nuts ourselves? And we didn't have to wait for it to fall from the tree to crack open. I mean, I'm kind of going way back in time here, right? So technology operationalizes ideas or theories. And so that's why I'm pairing them together. The other thing that's not intuitive about the intellectual category or adjective, or term, is that it's the adjective for idea, which again does not occur, or it's an adjective for idea. And again, going back to graduate school history training, you learn that historians of ideas, historians who do history of ideas call themselves intellectual historians. And that's what I was like, as a graduate student, I was like, oh, intellectual's the adjective for idea. I had never thought about that before. So we're using intellectual here to name one of our categories. Those factors, those determinants that have to do with ideas, yes, but also concepts, theories, anything that's explanatory, especially, we could put in our intellectual category of analysis. So that's why I've paired them. Yeah, I said all of that. So that's why those are paired. Here's getting to the final pair. Probably the most challenging pair, and you can imagine why. Challenging because the other categories describe sort of are categorical pots for phenomena, but these two are categorical pots for us, right? For people, for our fellow humans. So that's one of the reasons they're more challenging. They are reductive. And so, well, the other categories were reductive too, but these are reductive and they're about us. So they can be potentially offending, they can be misinterpreted, they can be misused because they're about us. And learners and teachers, everyone in the room, when we're talking about this, I mean, clinical learners are often apprehensive about talking about gendered or racial ethnic categories. And at the same time, social media, I would say, has exposed so many more people, including our clinical learners, to the idea that these factors are in play in our daily lives, right? So they're important to talk about, not just our clinical learners, but the general public. So I find they need a little less explanation, like the way technological category does, or social cultural, but they need more attention and time. They almost need more encouragement, clinical learners I'm talking about now, encouragement to consider them, to use them in their thinking, as a positive way, as a positive tool, use them as lenses to focus and identify these particular types of factors in their clinical work. So, for example, that a gendered determinant, a gendered factor, refers, yes, to binary concepts of male and female, but to also explain that a gendered factor, that's the use of, or the act of challenging these binary concepts as well. So that would be a gendered factor, pushing back against the binary where it's used to restrict people, restrict access, to oppress people, to rank humans according to some definition of male and female, or also that can cause pain or illness, right? So the skill is to be able to, again, talk to a patient, think about a clinical situation that seems incredibly socio-culturally complex, and be able to start to see different types of factors at work. For the racial ethnic category, I typically spend more time discussing and explaining this category of analysis, or more care, I would say, because it's a sensitive topic that requires that great care, because everyone in the room is implicated. I'm implicated. We're all racialized, for example, because no one can identify or be told, be identified. And again, that's another thing that is helpful, I think, for clinical learners to think about, that sometimes people embrace, sometimes the identity is imposed, right? Same for gendered. Where was I? Right, that we're all racialized, that some of us are racialized to enormous unearned advantage and others to unfair disadvantage. Again, talking specifically about race, but this is also true of religious identities, sometimes ancestral identities, sometimes regional identities, sometimes linguistic identities. I work in a medical school and institution that is officially bilingual, French and English, and there's a lot of language politics, and there's a lot of linguistic identity happening, and so we're attentive to that. I would say most importantly, hoping that it's not news to them, hoping that it's not information that is new to them, I emphasize that the idea of distinct races is a social construction and a human invention, disproved by science, the science that they're studying, that's used to justify very real racism, harmful racist policies, etc. So so this is why it makes it so, for me, this is why it's so important that a new physician is able to spot it, right? Because if you don't practice seeing something that's racist in the mess of context-dependent phenomenon, then you're gonna miss it, or you're gonna think about it later. It's just being able to look at something that's complex and just be able to identify it, and helping clinical learners to be comfortable with doing that. And I also acknowledge out loud that Anglo-American society, at least, which is my context, including medicine, Anglo-American medicine, still operates on the fallacious idea of white supremacy. And so that's why we all need to be working towards dismantling that white supremacy for those purposes. Again, so you need to be able to spot it to help do that dismantling work. And then there's also the point, maybe I said that already, is that a lot of times humans take on an identity willingly, proudly, right? And that is also important for our clinical learners to be able to identify, like I'm Irish, or I'm this or that, or I'm non-binary. So again, it's just facility with being able to recognize or identify. It's so much more, I'm sort of bumbling here and petering out because it's so much more complicated. We know that. And the whole point is reduction, which is I'm about to get to. So here we are. I'll just wind down this part of it, this rational part of it. So there are plenty of historians, epidemiologists, clinicians, and patients who will say these categories are reductive, simplistic, and they flatten the very complexity we seek to understand. So honestly, that's what makes this pedagogy so effective. At least that's been my observation using it for the last 8 years, almost 10 years now, with medical students. The technique, I could say, is like an artificial sectioning of sociocultural complexity and focused study of isolated components. Well, any of you with medical training, that will sound familiar. It's strikingly familiar to how medical students learn anatomy and physiology, right? Through a close examination of isolated tissues and systems. And no one ever worries that they're going to lose sight of how complex the human body is, right? If we ask you to dissect the arm and know it inside out, nobody's worried that they're going to forget how complex the human body is. So that's my argument. And so I found it especially effective to compare, when I present this to clinical learners, to compare the categories to histological stains. And this is another technique that's really familiar to medical students and physicians and scientists. And I explain how, just like stains do for tissues, each category or tool highlights or clarifies a particular facet of sociocultural complexity. And just like histological stains, when you apply it, it simultaneously minimizes or distorts other facets. So you can see the one facet more clearly. So yes, they are reductive, just like stethoscopes, just like imaging and electronic medical records. Those are all reductive. But it's a temporary reduction in order to make, for example, a person's health situation more clear, in order to expose inequities in both the formal systems of medical education and in the hidden curriculum. And these tools require skill to use to effect that kind of equitable person-centered care. And again, the core skill of this pedagogy is for teachers, learners, and providers to be able to efficiently learn and get to be using these tools to evaluate socio-cultural complexity, temporarily dismantling it into different subtypes as necessary. And in order to identify the target, in order to identify and target specific determinants of health and barriers that need to be demolished to meet equity, diversity, and inclusion goals. So that's the rationale for doing it this way. I know I haven't described what I do completely, but I thought it was more important that you understand the pedagogical rationale for why bother doing this. I'm eager to hear at the roundtable or afterwards. Yeah, ways it could be improved, critiqued, adjusted. So that's the rationale. And for the final little bit, I was going to have each of you, oh wait, I was going to give you, sorry, a description, a little bit about what I do. As I said, after I explain the 8 categories, I use a history lecture, basically a short history lecture on something. Most of history is pretty socioculturally complex, but you choose something that's sort of juicy and a lot of detail. So I often use history of epidemics. And what I'll do is I'll do a very packed 20 minutes on the last 2,000 years of epidemics. And then I leave out the so-called Black Death, the medieval plague in Europe. I just leave that part out. I say we're going to skip over the most famous epidemic. So I talk to them about all kinds of different epidemics over 2,000 years. And again, I stop and start and say, you see how that's social? Because this is a social factor going, because they decided the horses and dogs should not be rotting in the streets anymore. And so they effected a policy to do a public health cleanup. And that's so I stop and say, look, here are the different kinds of factors. And we see in this painting, that there's these new representations of death as your constant friend after the plague, and they're trying to make meaning. So I won't deny it relies somewhat on my performative skills as well and my ability to connect with learners, but we all have that challenge. So I'm pointing out how the categories apply to the sociocultural complexity as we go. So that's how the session works, is I present that this is a good thing to know. I take them through the definitions of the 8 tools, and then I show them in a historical case study how you could see the different facets or stains or ways of looking at it. And then we take a break, of course, and then they come back and they do it in groups by themselves. They get into groups, and that's when I give them the Black Death. I say, okay, here's your epidemic. And before the pandemic, I used to bring in materials, books and images and all kinds of things. But I also told them, Google it, go ahead, look it up on the internet, whatever you want to do. But what each group has to do is come up with an example for each category from the epidemic. After the pandemic, the COVID pandemic, I also use the COVID pandemic. It works really well as well as it's just material. You just need some sociocultural complexity that they can try to disentangle using the tools. So then the groups come up with an example for each factor, each tool. And if we have time, sometimes I have them present them really quickly. Inevitably, both groups have 2 completely different lists. And then, especially if we have time, I say, okay, now rearrange yourselves in the order of importance that these factors are for explaining what happened. Because that's what historians do. We explain what happened. And that's what pathologists and diagnosticians do as well. You're trying to get a causal explanation of what is going on in the phenomenon you're looking at, whether it's your patient or a disease in a population or the Black Death. So then they have to rearrange and say, well, gender isn't that important, and they're all rearranging themselves. It sort of gives them that very quick and dirty sense of, we're not saying technology is the most important factor in this example, but it's there. You can't have the Black Death without shipping and travel around Europe, so that's what it is. How do you feel like we are for time? Yeah, we're good. That's what I thought. Okay, good. So what I'll do is the last little interactive thing I wanted everyone to do, both online and here in the room, is perhaps use the COVID pandemic, which we all lived through. We all have those details probably at the ready, and just ask yourself, to just challenge yourself to find an example of a social factor versus a cultural factor, and see if you can make a pair like that with examples from COVID in your own mind. And for anyone who wants to show off, and can I go back? I can't go back, right? To the social cultural slide. Yeah, thank you so much, Sally. So using the definitions I'm proposing for the clinical learners, can you think to yourself two examples from the COVID pandemic that meet these criteria? And we'll just be in silence for 60 seconds. No pressure. And then I'll ask if anyone wants to volunteer their examples. Who has at least one in their mind? Oh, yeah, getting there, getting there. Does anyone have two yet? Does anyone have both yet, do they think? From COVID. Oh, yes, excellent. Give another 20 seconds. I know it's pressure, but you're an advanced group. It's also very counterintuitive until you force yourself to do it. Alberto, are you willing to share? Ah, thank you. Thank you. I appreciate, I always say to the clinical learners, thank you for being brave.
The obvious example is lockdown.
Is what? Sorry.
Lockdown.
Yep, lockdown. Yep.
Like social dimension. And there are all these dimension of privileges, hierarchy, institutions.
Yes.
Because
hierarchies.
Because sometimes lockdown was kind of selective, we affected people differently. So this kind of structure is a huge structural societal change.
It was.
Social aspect. Culturally, I mean, it depends on, so the aspect of meaning of lockdown is interesting because people got polarized around that, but some people interpret lockdown as kind of sign of authoritarianism.
Yes. How did people make meaning from the social, the legal imperative that you are not allowed out by law? How did then people make meaning from that social intervention?
It was a way of acting community.
Yes.
So people got polarized around. So culture is always fragmented in this sense. Actually, cultures emerged from the structural change. So we probably didn't know we were so divided until a structural change emerged, and then we realized we disagree on basic values like protecting community or the role of the state. But until the structural change occurred, we didn't know we disagreed about that.
Okay, I want to repeat that especially for people online, not all of it, but you propose that culture emerges, culture emerges from structural change.
It's the loop.
It's a loop. I was going to say, yeah, it's a loop. I'm using you as fodder, so thank you, because obviously we could talk endlessly because we have the training. Alberto's a philosopher, for those of you who don't know. Of course it's a loop, and of course they're interconnected, and that interdependent, not just interconnected, but interdependent. This is one of the insights that I hope clinical learners will take away is, yes, it's all interdependent. You can't just pull out a cultural factor and think that the whole thing isn't going to collapse. I get that. But like a histological stain, you could obscure some other factors while you concentrate on really thinking about this one. So that's one thing. So yes, lockdown and then interpretations of what lockdown means. Is it a protection of the community? Is it a violation of rights? Is it this horrible thing? Yeah, how people make meaning from it. Of course, the discussion is much simplified a lot of the time as the students work through these things, but the goal is that they're going away with a new framework for thinking about a lot of these things. Anyone else want to share one or both of their examples? Another brave person.
I mean, I can think of loads of cultural ones, but then the social ones are often very political in the context of COVID, so thinking a bit about that. But I was thinking about the whole social aspect of isolation, isolated home, and this idea that everybody has a home in which to isolate.
Yeah.
All of the things that came with it. And then the cultural, I was thinking, I think it was actually the Prime Minister of New Zealand that invented or brought it to use the term bubble.
Right.
And how incredibly culturally resonant it was, this fragile thing that you kind of enclosed in as you isolate.
Yes, yes, the bubble.
Rainbow is here.
Oh, great. Yes.
Symbolism of hope, and
Yep.
thanks to the NHS, incredibly resonant in the pandemic here. You still see rainbows.
Still see rainbows. Yes, yes. So this cultural significance of the rainbow for hope and the cultural significance of the bubble, because again, excellent examples of meaning making, not simplistic, which is where we're going to leave it. But excellent examples. Yeah, I'd never had the rainbow before. We had the rainbow at home as well in Canada. I want to move to questions. Okay, good. Please go ahead. Yeah.
Always upbeat from Wendy, though. So it's complicated because of intersectionality. At the time, what struck me was racial disparity, which were social and structures of work that predisposed some racial groups with more exposure due to their work, and cultural because of meaning of family and large social group members as being most important to their lives. So mixing occurred more often. I hope that makes sense.
It does make sense. I hope everyone was able to hear it online. Do you have I hope you have a microphone on your, okay, good. Okay, good. Yes, thank you. Yeah. That you've given me a great final thing to talk about in terms of the using it as a teacher. And that is the natural inclination in the discussion will be for the learners to go back to the ways you cannot separate it. That's the challenge for the facilitator, I find, is yeah, but let's try to separate structural from meaning. Just this, and then that is the thing they go away with, though, is that you can't. They're interdependent. But I can try. And in the trying, you may get more clarity. You may get more clarity with your patient who has one interpretation different from yours, right? If you think about the intellectual type, the intellectual factor, I mean, that comes, a patient who's vaccine hesitant. Why are you vaccine hesitant? Well, because they have a different idea and theory of what vaccination, they have a different way of explaining vaccination than you do, doctor. Right? So you have this intellectual determinant of health, I would call it, not about their intellect. I mean it in the way historians use it, that it's an intellectual factor. The reason I'm not connecting or understanding my patient is because I'm not understanding how she explains vaccination to herself as a theory. And maybe that could be helpful in a consultation. So thank you to the last comment that sort of said, they're interdependent. And yeah, I didn't talk about oh gosh, I just blanked on the term because I've got interdependent in my mind. Intersectional analyses, which of course are very important, but again, trying to get to where the clinical learners are in time and space and give them something useful without getting too much into the weeds of high research. So I'll stop there. Thank you so much for your attention.
Thank you, Susan. And I'm so pleased we have a roundtable because there's just huge amounts to unpack
Yeah.
from that. So thank you so much. So as you know, we have a roundtable discussion and we have a good 45 minutes to unpack Susan's talk. But Susan has very kindly volunteered 5 minutes in case anyone has any burning questions now before we go into the break. And also if anyone online, because unfortunately you guys won't be able to join us for the roundtable, whether you have any questions. And I think Susan would be happy to answer.
Sure.
Richard.
Burning question. You said you let students Google things in these sessions, and I was wondering if you let them use AI now as the new thing that they will use.
Yeah. I haven't, because I'm on sabbatical this year, and it usually happens at the beginning of the term, it actually feels like it's been over a year. And it feels like it's only become really in our face. Like the last group of students I worked with whom I worked, which would have been September 2024, they didn't ask. And it didn't occur to me, to say anything. In this context of this learning session, I don't think it would matter because we're not fact checking, we're practicing. If that makes sense. We're trying to test out and practice the skill of disentangling using these analytical categories. So if the facts are wrong, I would imagine that would come up in the discussion that, hey, is that true? Like, I don't know. So yeah, it's a good question. I think I might. I actually found the first time I used the pandemic, which won't last forever, right? Because generationally, the medical students are not going to have lived through the pandemic in the same way anymore. So that might be on its way out. But for the last 5 years, it's been a very tangible, they didn't even have to, they just used their own imagination, their own experiences to, about what they saw in the news. So it's a good question. I suppose we'll all have to confront that, but yeah, you could control it also by bringing in materials and saying, put your phones and your computers away, just use the materials that I've given you. That requires more time though.